I think radiation is a question I also wanted you to address, because radiation is not a benign treatment. It certainly has its advantages in certain circumstances, but can you address maybe how does radiation potentially affect some of these reconstructive options down the line?
Yeah. We would all agree that the oncologic treatment deserves priority over any reconstructive treatment. And things that improve your prognosis certainly deserve priority over that. Having said that, the thing about radiation, which can be frustrating, is sometimes the effect of radiation in terms of the cosmetic or appearance-related or functional effects of radiation don't show up till later on. And radiation and certain types of reconstruction don't do real well together. And therefore, there's judgment calls in this, particularly radiation and immediate reconstruction. So if you know a patient's going to need radiation, they may be one of those candidates that some physicians would certainly delay having reconstruction. Some people don't feel that way either, based on quality of life, but that's that controversial area. And I think that when you're looking at the entire treatment plan, we need to think about how much better prognosis does radiation deliver, because there are some downsides to radiation, versus some of the psychological and emotional impacts of a less than stellar reconstruction or no reconstruction at all.
Okay, we're going to switch gears a little bit. So, insurance, something that's on a lot of people's mind these days. So, does insurance cover breast reconstruction?
Fortunately, it does. There have been some very important acts made by government to support reconstructive surgery following mastectomies. And although it's an interesting point, because as we are getting better in our reconstructions and our goals for the cosmetic result to be better, the insurance companies are now slowly trying to say again that this may not be reconstructive, it's more cosmetic. On the one hand, I take it as a compliment that we're doing such a good job. On the other hand, it's still not fair to our patients who are going through this process. And so most of the time, everything is covered. But it's incumbent upon us and our patients going forward that we keep the pressure on to make sure that these procedures are covered by insurance.
And that also includes symmetry procedures on, say, an opposite breast, correct?
Exactly, because I think, again, when you're thinking about a patient in whole, fortunately, breasts come in pairs, and having one nice looking breast on one side and a breast that's nice looking on the other but doesn't match is not the ultimate goal. The ultimate goal is to be able to look good in your clothes, in a bathing suit, naked, to be able to put your clothes on and get dressed every day and move beyond this experience of breast cancer.
Yeah, I think that the advances in reconstruction have been incredible, and I think, just as you're alluding to, there's patients that say after their treatment and their reconstruction, I look a lot better now than I did before I had breast cancer, as far as their actual cosmesis of their breast. The last question about reconstruction I want you to address is we have an email from a patient asking, is it harder to detect a tumor if you have an implant?
Another good question, and the answer by and large is no, because if you have some sort of implant reconstruction after mastectomy, the breast tissue is removed, and therefore there aren't post-operative mammography, therefore the implant does not get in the way of any visualization, but you do need to be continuing to see physicians who are comfortable with implant reconstruction, so that if you have questions about sensation or new feelings or palpability, that they can differentiate between what's an implant and what's not.
All right, Lou, so you came all the way down here, so I'm going to have to work you hard today. Now, you're not only a great breast reconstruction surgeon, but you actually have a particular expertise and interest in facial rejuvenation. We have questions of the week here in Plastic Surgery Talk, and we have one on Twitter that's asking about what is the difference between a regular facelift and a mini lift. Could you address that?
Sure. These are all very timely questions. In 2009, the mini facelift really has become very popular again. But I look at it as more of a marketing message to the public who love the ideal of an operation that provides a very quick recovery with very little discomfort. And the mini lift has been used to describe many different operations. If I was to generalize, mini lifts are lifts that use the skin as the primary tightening mechanism. They're an operation that aren't too different from the operation that was described in the 1970s, but we're using 2009 marketing messaging to regain popularity. The problems with the mini lift are really, we're not thinking long term. Short term, you can tighten the skin and patients will look okay. But facelifts today, done well, are far more than just skin tightening. Rejuvenation procedures, or the classic facelift today, elevates more structures than just the skin. And if you're just trying to tighten the skin or do some little lift in the muscles, you're either going to get too much tension in the skin, which is going to make people look kind of flat, or you're going to get widening of the scars, or you're going to pull the skin in the wrong direction. Facelift today really requires adding volume back, addressing the muscles and the gravitational changes, and then redraping the skin in a comfortable, natural way. And again, just like the advances we've made in reconstruction, we've made tremendous advances in classic facelift surgery, so the recovery in facelift surgery is not what it used to be. And that sort of spectrum between mini lifts and real facelifts have become narrower. It's just that the marketing messages of mini lifts have been so profound.
Okay, we have one other question I'd like you to address, and this came through our website at the Ask Dr. Bill link, and it's from Aisha Salem in the UK, and you can answer it without the British accent. I know you like that. You do consider yourself somewhat of a James Bond character, don't you? Anyway, it says, I am 39 and a half years old. My smile lines are becoming more pronounced. I had very little lines before, and now I'm becoming more conscious of them. Can you please advise what I can do to make these look better?
Well, Bill, tell me about smile lines. Are we talking about the lines around the corners of the eyes or the lines around the mouth?
Let's talk about both those. I think let's say they're the lines around the eyes to start with. What can we do?
Yeah, you know, it's no longer smoke and mirrors. We know the origins of lines today, and the lines, for instance, around the eyes have to do with the elasticity of the skin, and a patient who's approaching 40 starts to lose a little bit of elasticity. But moreover, those lines occur because of the redundant or repeated contraction of the muscles around the corners of the eyes. And that's an ideal place for Botox to relax the muscle, not allow it to constrict. And if some of those lines or smile lines are persistent, even when patients aren't smiling, then you have to treat the elasticity component. And those are usually done through peels or lasers of some sort. That combination will take care of a significant majority of the lines around the eyes, those smile lines.
And then what about common areas, nasolabial fold, or what's called the marionette line? What kinds of things can be done for those?
Those lines are more deflationary. And I think what we've really learned recently is that if someone has a deeper nasolabial fold, oftentimes the volume isn't lost right in the fold. It's really lost above the fold, and the fold deepens. So to just treat the fold in isolation with a filler, and we've all heard about many choices of fillers, it works okay, but if you want to get longevity, you've got to be thinking beyond the fold. And I think that volume restoration, particularly in the 40-year-old, very predictable time when people start to see a little bit of deflation in the facial area. And volume restoration is a very good approach to the patient who doesn't have gravitational changes, but volume loss. So I think fillers are good in the fold. The marionette line, the lower face, is a little tougher because there's a lot of motion around there. But nonetheless, using a fairly robust filler deeper and a gentler filler superficial to that, or a combination of fillers, works very well. These are not as much motion or Botox areas as there are pure filler areas.
Oh, that's great. And Lou, it's been great having you on the show. I think your insights for all of this have been very, very helpful to all of us here, and I'm sure the viewers will appreciate that too. So thanks again, and appreciate everything.
Thanks, Bill. Love being here, and thank you for asking me.
So our mission here at the Plastic Surgery Channel is to make sure that you, the viewer, have all the information you need about your options when it comes to cosmetic or reconstructive surgery. So let's hear from you. Send your questions that you may have about reconstructive surgery or cosmetic surgery to theplasticsurgerychannel.com. You can also join our Facebook page or send us your tweets on Twitter. Thanks for joining us today on Plastic Surgery Talk. We'll see you soon.